get into the subjectivity of suffering, first thing, generational, right? So love this picture. You can always hear him say, "Back in my day, I traveled up hills both ways to school and wrestled an alligator at the top of the hill." You know, so there's certainly this generational aspect of suffering, and I think we've all had our grandparents, our parents tell us all how the hardships used to be, and we don't know what it's like anymore, and we're so coddled at this point. And then when you think about it in the the medical sense, and certainly attendings that we've had, or doctors we've heard about in the past. I mean, how many doctors do you think rolled their eyes when they first talked about reducing duty hours, right? I mean, they got there, they went through it, they did fine. They're there where they are, right? And my own father, I mean, as nice of a man as he is, he kind of laughs a little bit at when I tell him about our call schedule here, and when I tell him about the work we've done or work we do or have to do, and he's like, "Oh, I used to fall asleep kneeling on the bed reading my book." It's like, that's really cool. I'm happy. But anyway, yeah. So just wanted to talk a little bit about that. Get in a couple studies I found, a couple editorials. One from 2004 talking about how there has been a sort of gradual shift from the baby boomers to the Gen Xers, whereas baby boomers and beyond and before them kind of saw this induction into this elite medical fraternity, right? Working long hours, missing major life events, not sleeping, falling asleep at your bed, kneeling, reading a book, like to now these, they found these Gen Xers who are now, and I'll even include, just in case you guys are curious, because I forgot, but I'm sure there's plenty of millennials in here. I myself am a millennial, but yeah, wherever you fit into this category, just as a reminder of what I'm talking about. But they did find that the Gen X population started to, we're not only interested in the medical education, but we're also starting to be more equally concerned with life outside of medicine, right? Like your life, your rest, your hobbies, things like that. Another study from JAMA in 2003 found that specialty preferences changed significantly from 96 to 2002, and controllable lifestyle explained more than half of that variability. And this is controlling for things like income, work hours, and years of training for each of the specialties. So controlling for that, they still found that people were kind of looking more towards like lifestyle stuff. And that's Gen X. And I think that trend only continued. I mean, I myself have said the term work-life balance how many times since I've been here. And then kind of getting into more recent, I did find a study, and this is kind of shifting gears a little bit, but a study in 2019 showing results of a survey from about 2012 to 2016 for med students. They actually found that fourth-year students ranked statements like enjoying the type of work I'm doing as less important to a good physician lifestyle than did first-year students. While lifestyle factors like having control of work schedule and having enough time off work were ranked as more important by fourth-year students. So it kind of just shows that, and Dr. Nemchek and I were literally just having a conversation of how we've changed as first years to fourth years, how your values change. And sure, you can say we get jaded, we get cynical, we get beaten down by the system, to be dramatic. But our ideas change as we go through. And you can put that up to many different reasons, whether it's the job, whether it's the people, the superiors, the attendings you work with, the patients you work with, X, Y, Z. There's multitude of answers to that. But anyway, moving on, as well as generational, it's also cultural. Now, the picture I have there is a little generational, I'll be honest, but I do love Calvin and Hobbes. I grew up on it, and I wanted to include it. And the whole idea of it builds character, right? So, certain cultures do tend to kind of see the more positives in suffering, and where is the silver lining? How can I build from this? One study I found, this is actually related to COVID-19. There was a lot of studies I found when I Googled suffering for COVID-19, but they found that in 2021, there were cultural differences in Euro-Canadian students versus Chinese students during the COVID pandemic. So they did multiple studies. The first study was just a very free association, positive to negative, and they found that Chinese students were more likely to associate positive meanings to negative words. Second study, they had participants create this hypothetical potion where they added ingredients into the potion of someone who had experienced suffering, and those ingredients were more positive from the Chinese students than compared to the Euro-Canadian. And then lastly, last study, they essentially just they did the study to represent what others would be experiencing from COVID-19 and what they would suffer through, and they just found that a greater proportion of potential positive outcomes were found or were listed by the Chinese students. So again, it really just showing that there are cultural differences that exist when you think about suffering. You know, in that article, they sort of talk about what those differences could be related to. One example I'll give, and this kind of leads me into my next point, is, you know, I think it's important to take into account that there are religious differences as well. And, you know, religion and culture definitely do have gray areas there, and they do coincide a lot. And myself being raised Catholic Christian, you know, I have more to speak on it, whereas I only have as much as I can research about like things like Buddhism and more Eastern dominated religions, you know, Buddhism, Taoism. But the biggest distinction that I found that they talk about in this paper is how you view suffering, right? So for the Euro-Canadian, which tends to be more Christian Catholic dominated, and I'm sorry, I don't mean to make this like a theological discussion. I just want to talk about this point. You know, we tend to see suffering, or the Christians tend to see suffering as, you know, this consequence of this mortal sin. We're suffering because we're being punished, blah, 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 blah. You know, what they drove into my head when I was a kid in CCD, you know, stuff like that. So that's kind of how we're taking suffering from our history and with that religious aspect to it. Whereas on the other side of things, the more you know, Eastern dominated, kind of like more Buddhism, Taoism, Hinduism, suffering tends to be more of a baseline. It tends to be more, you know, life is suffering, as Wesley says, life is pain, Highness, right? So it's not as much as like you're being punished for this. This is your fault for this suffering. It's more just life is suffering, and we have to learn to grow through that suffering to achieve, you know, enlightenment, transcendence, you know, whatever that may be. So that is one thing they talk about, and why that discrepancy could exist, or why that difference may be apart. And I'm sorry, just talking about there are some positives that we do find in religion and faith, and you know, it's not all suffering is sin and you're suffering because you did bad. You know, we can have a tool for suffering. It can be our sanctification. It can be a way for us to look inwards to better ourselves, and it can be something that we can use as a test of faith, right? Something we can use to strengthen our resolve. Lets us know that we're able to test our dedication, and like, this is what I really want to do because I can get through this, and that's in many aspects of life. So going on, this is the Times article that I really liked, that actually, of course, it was COVID related, but again, they barely talk about COVID. They more talk about suffering and you know, what we can gain from it. And this actually kind of made up, this was the first thing I found and what made up a lot of this talk. But that's kind of where they talk about, or the basic gist of what they talk about, and what I'll kind of get into a little bit more as we move on. But one quote they have in there, and I thought this was pretty funny. This is from William Henry Atkinson, the president of the American Dental Association. "I wish there were no such thing as anesthesia. I do not think men should be prevented from passing through what God intended them to endure." Now, granted, this is from like the 1850s, so take that with a grain of salt. It just so happens that a little history lesson, back in the 1850s is when anesthesia started to kind of come to light, and when it was introduced, and it was not taken well initially. It was really taken as like, this is a masking of suffering, and you're supposed to suffer. And they called it a quagmire of quackery, or they called it satanic influence. Very dramatic. That was the word they used to introduce anesthesia. But it just goes to show you that like, this was 150, 170 years ago, sure, but you know, when you take that baseline and you transform it into today's age, you know, that still existed, that mindset existed. So something that was so crazy, so foreign, so satanic back at that point, now is something we know that is so like helpful and that we can use to help people. So just an interesting thing that they talk about. But another thing they talk about in that article is the term anti-fragile. Now, anti-fragile is a term from Nassim Nicholas Taleb's Anti-Fragile Things That Gain from Disorder. I personally have not read this book, I'll be totally honest, but I did do some research on it and found this word, which again, they talk about in the study. in the Times article, excuse me. But as you can see, you know, we talk about, when we have our suicide risk assessment, we talk about resiliency, right, as a protective factor. And, you know, as they show resilience in here, it's the ability to resist shock and stay the same, right? But kind of going one further is anti-fragile. So it's the ability to resist shock and get better, right? And that's not something I think we really talk about quite as much, especially in our, you know, protective factor. That ability to not only take it on and be fine, but take it on and get better, right, from. So again, something that they mentioned in that article. And a study I found that kind of goes into this a little bit. In 2013, they gave people a list of like 30 some, I think it was 37 negative life events, right? Just a total list: physical assault, death of a loved one, so on and so forth. Just negative things that can happen. They tallied up how many of these people had experienced these negative things in their lives. What they found was those who suffered minimal to no negative experience in their life actually ended up having lower pain tolerance and a higher tendency to catastrophize. Whereas they found that those who actually had suffered, who actually had some of these check marks on the list, had a higher pain tolerance and a lower tendency to catastrophize. But then going further, they also found that there's the other end of the spectrum, that those who suffer too much, who hit too many of those tallies on the list, found that they were kind of similar to the first group, that lower pain tolerance, higher tendency to catastrophize. So that kind of makes you just realize that there is a sweet spot, a little suffering sweet spot, we'll call it, that you all may recognize what this is. What do we have here? Who can tell me what that is? It's a bell curve, right? So we talked about it in our objectives. I drew that myself, by the way. I didn't. But yeah, the bell curve of suffering, I would like to introduce that. You know, the idea that, you know, we talk about this with anxiety, we talk about this with anything, right? Everything in moderation is the idea. You know, I tell people this all the time when I'm talking about anxiety. You know, you have the bell curve of anxiety. If you don't care at all, you're not going to do well. If you care too much, you're not going to do well. But if you care just like that nice little amount right in the middle there, you have anxiety, you have stress before a test, you're going to do well. So in the same sense of, if you go through that suffering, it can have positive impacts on you. So again, another study that they talk about in 2016 that shows the severity of past adversity can predict increased empathy, which in turn is actually linked to a tendency to feel compassion for others in need. So what they found was people who haven't really suffered much at all in their lives were less likely to agree with claims like, it's important to take care of people who are vulnerable, or when I see someone hurt or in need, I feel a powerful urge to take care of them. So they're less likely to agree with those comments, and they're less likely to donate to needy strangers, compared to others who have gone through adversity. They were more commonly able to agree to those claims and to want to donate to needy strangers. But you know, compassion is what we're all about, right? I mean, that's what we're here for. We want to help others. We want to donate to those in need. We want to help the person on the ground. We want to give a buddy an arm to pick them up, right? We want to agree to those statements that I should help others in need. What they don't really talk about in this study is, like the previous study, what happens when you have too much, right? But I think we can kind of speculate, and I think we can assume that when too much is too much, we introduce another term, and I'm gonna let our fiery Elmo tell us about it. Burnout. Right? So we introduced the term burnout, right? So burnout. Christina Maslach, you may have heard of her. She wrote a book, Burned Out, and in that book she's quoted, "If all of the knowledge and advice about how to beat burnout could be summed up in one word, that word would be a balance. The balance between giving and getting, the balance between stress and calm, the balance between work and home." Right? So I think our previous slide showed that very well, that balance. And I think that, you know, that bell curve is so important, because that balance is what we need to achieve in our lives and what we need to help others achieve. Because I think if we don't have that balance, we're going to burn out. And if we're not helping our juniors, and it has in the past. Myself personally, I've been burned out. You know, you get over it, and you look to your friends for help, but you know it's there, and it can happen. So I want to make sure that we're able to talk to each other and having these conversations with our friends and colleagues and attendings that, hey, I'm having a hard time. So moving forward a little bit more. So we'll spend a little time here, but Maslach has this burnout syndrome, right? And she invented this burnout inventory, the MBI. And in that inventory, just to give a brief description of burnout, right? She defines it as a state of physical and mental exhaustion related to caregiving activities or work, right? Now, obviously, you can expand this beyond caregiving activities. It doesn't necessarily have to be that, but for our purposes, yeah, sure. But in this MBI, she talks, there's about 22 different things divided into 3 subscales. You can see those 3 subscales on the board: emotional exhaustion, depersonalization, which is not exactly how we think about it, so take that as it is, and reduced personal accomplishment. Okay, so emotional exhaustion, a lot of these speak for themselves, but feelings of overload and depletion of emotional resources. This on the scale, this evaluates the complaints about feeling on edge and feeling exhausted by work. Depersonalization is defined as the negative response to other people, such as colleagues and patients, in a cynical and isolated way. And this measures impersonal responses and lack of empathy during professional activity. And then finally, reduced personal accomplishment, when the subject feels less competent in his or her role, and this evaluates the feelings of competence and achievement of success at work. Okay, so I want to let that sink in a little bit, and I want to let you kind of apply that to your life and just to your time as a resident here, and maybe as a medical student. And I think this goes a really long way, and I want to carry this theme through the rest of this talk, because I think it's really important, these three kind of core values, and I think they go for a lot of things. You see these percentages down here. I did find some studies on burnout rates. They were able to get some rates here. In 2004, there was a study done that they reported an overall burnout rate of 50%, which, I mean, that's half. That's a pretty solid amount of people feeling burnout. Obviously, it got better in 2018, so it did improve, which is great. But in 2004, most of the biggest specialties were 75% in OB-GYN, 63% in internal medicine, 63% in neurology, which actually surprised me, 60% in ophthalmology, 50% in dermatology, 40% in general surgery and psychiatry each, and 27% in family medicine. And then, so you can kind of already predict, like you can kind of tend to categorize that, right? You're more stressful in hospital, kind of residencies, specialties. We're having higher burnout rates for things like family medicine, which are a little more calm, outpatient. We're having less burnout. Then the other study in 2018, again, they found a drop in the overall burnout rate down to 35%. They found that things like OB-GYN was again the highest, general surgery, OB-GYN, orthopedics, all averaged out to about 40%. Internal medicine and surgery and pediatrics, plastic surgery and pediatrics were about 30%. And then neurology actually was 15%. So good job, neurology. They took quite a turn there. They improved themselves. Unfortunately, I didn't see psychiatry on this one, and I looked at all the tables and charts, and they just didn't include it for whatever reason. But you can kind of see neurology is obviously part of psychiatry, and they did a lot better, which is great. And for the most part, I think we're doing pretty well as psychiatry in that sense. I think we're very good at taking care of each other. So here, getting into, we can't talk about burnout unless we talk about attrition rates, and kind of negating what I just said about psychiatry. This was data mined from about 20 major specialties from the academic years 2010 to 2011 to 2019 to 2020. So this is, you could say, about the last 10 years, give or take a few. But they collected this from ACGME Data Resource Book. And as you can see, the annual attrition rate is pretty darn high for psychiatry. And I mean, we hear it all the time, we need psychiatrists, but a lot of these make sense, right? Some don't. Orthopedic surgery is way down there. That surprised me too. Surgery is up there. I got that tracking, right? But psychiatry is way up there. And I think that it's important to take some time right now to think about why that is, right? And I have my own opinions, and I'm sure everyone here is going to have their own opinions on it. And you may agree with me, you may not agree with me, that's fine. But we're just thinking about reasons, right? And I think psychiatry in itself kind of has that X factor, kind of has that unanswerable question, and why I wanted to do it so bad. I mean, you heard Chelsea when she was introducing me. I love philosophy. I love those questions that don't have answers. And I think that it's a double-edged sword in that, you know, you want those questions that don't have answers. I don't know if that's the right idiom, catch-22. I don't know. Either way. You love those unanswerable questions, that kind of introducing the art into the practice, but it also comes with a lot of stress because we don't necessarily see people get better all the time. And, you know, orthopedics, bone broke, fixed bone. I'm allowed to say that because my dad's from orthopedics, right? Bone's broke, you fix the bone. Bone's fixed, right? Now, obviously, I'm simplifying it. I'm sorry, orthopedics out there, if you're listening. But there is a lot more unanswerables. There's a lot more. You don't quite see the results, and that can take its toll on you. And when we're talking about Maslow's inventory, emotional exhaustion, anyone feel emotionally exhausted sometimes? Raise your hand. Yeah? No? All right, yeah. Pretty much everyone. Right, so we're getting these patients who both are going to make us feel emotionally exhausted, and we're feeling emotionally exhausted back to them, right? And that's so hard to do. And again, that's just the first thing we're talking about. Depersonalization. You know, again, I know it's not exactly how we define it, but it's that negative response to other people, colleagues, patients, in a cynical and isolated way. And we talk about countertransference and things like that. But again, we're hitting a lot of these symptoms of burnout. Right now, again, I say we. I'm speaking very generally. If you're not hitting them, great. But these are being hit, especially in the psychiatric world. Okay. And then PA, right? Reduced personal accomplishment, which I think is a really, really important one, because I think that is a big thing that goes with attrition, right? When we're talking about personal accomplishments, when we're feeling confident in our role, when we're feeling like we're achieving success at work, that's great. And that makes us want to keep doing it, right? But when we're not feeling that way, especially in something like psychiatry, where it has those unanswerables and it has those patients who don't always get better, get a little better, but you know, they get worse again, they get better again, right? That's hard. And that could be an explanation of why we see psychiatry so high up there. Okay, so it's just more important. It really is for us to make sure we're checking in on each other, to make sure we're not hitting any of these. And if we are, that we can reach out and we can talk about it. And for my juniors, if I've ever, you know, I always want to make sure you guys feel like you can come to me, right? I always want to make sure that you can come to me if you're feeling that way. Or if I'm not facilitating you to not feel that way. If I'm not doing it enough, I always want to hear from you guys. I always want to know that we can do it, we can do better, and we want that feedback. So please bring it to us. So, what else? Right? You know, I've been a little pigeonholed here in talking about residency and talking about med school. You know, what else can we talk about? And I'm just gonna. Oops. There we go. You know, as you hear when we're interns and you're getting all those lectures from everybody, we wear two hats, right? So we have our medical hat, and then we also have, I apologize, trigger warning. We have that, right? So you may know who that is. I don't know if you've seen the movie or not, but yeah. Anyway, that's the whole other side of it, right? And this isn't just for us. This is for the people we're helping take care of, right? And I'll get him out of there so you guys don't have to. But that's a really big important part of it. Now, yes, we have to feel that too. We have to get that from, you know, our command and suffering and this, that, and the other thing. But too many times have I seen patients who are struggling with the rigors of their jobs, the long hours, the stressors, at times the boredom. A lot of times these guys and girls are doing stuff that they don't want to do. They sign up for a job and now they're doing something completely different. And they may just be sitting there with nothing to do, and they can't use their cell phone. They can't do anything. They have to sit there. That's suffering, right? Now, I don't know if you want to call it cruel and unusual. That might be a little dramatic, but the whole point of this is they're experiencing suffering, whether it just be at baseline, through their job, through just the nature of the beast, just like we are. They're suffering in med school. They're suffering in residency. It's built into the system, okay? My whole point of this talk is we don't need to add to it unnecessarily. And I think that when that suffering is compounded on itself, because of that mindset of I suffered, so you should too, I think that is doing way more harm than good. And I think we get past that bell curve. I think we get to that end of the spectrum where we start to hurt more than help. Okay. So that, I think, the whole point of these talks, the whole point of these grand rounds and what we're tasked as PGY4s, not MS4s, is to try to, whether it be change your practice, change your way of thinking, change something, make you think. And my whole point is to make you think. Again, I love philosophy. I just want people to think about stuff. Okay. I'm not going to sit here and tell you about receptors and this, that, and the other thing and give you cram a whole bunch of knowledge down your throat, but I just want people to think about this stuff. I want you to take it with you and apply it as much as you can. Right. So you can apply this to the military. You can apply this to med students, to residents. Hey, we got people in the military who are also healthcare givers, right? We got a lot of our corpsmen who are now getting it from all ends of the spectrum, right? They got patients, they got command, right? There's a lot of suffering built into the system. And this topic is broad. This doesn't just apply to us. This doesn't just apply to the military. It's all encompassing. And I think it's just worth talking about. And last thing, I don't think it's talked about quite enough. And this is my own personal experience as a med student, that work-life balance. We're here, they're here to teach us all about the medical stuff and learn about all the subjects. But I think it is really important for us as residents to talk to our med students about work-life balance and how we can help facilitate that. Because as you saw in that one study, they're going in as MS1s thinking, oh, all I'm thinking about is how great this profession is, how great this specialty is, which is all well and good. And I never want to squelch it. I never want to squander that. But I also think it's important to talk about that work-life balance and how we kind of keep people on for the long run. Okay. And then, lastly, potentially talk about, as well as attrition rates. And this is not something I looked into, but we can talk about XYZ forever about this and how this downstream effects is like, not only attrition rates, but not even attrition rates in residency or med school, attrition rates in the military, divorce rates of the specialties. How not only are these people leaving their jobs, but leaving their families, right? What are the downstream effects of suffering? Okay. So let that be a call to arms, right? And I've already kind of talked to you guys about this. I really do want to task each and every one of you, for your juniors, for your colleagues, to talk about this stuff and find ways to reduce suffering as much as you can. Because again, suffering is built into the system. We suffer a lot. We suffer enough. Try to alleviate it, right? And try to talk to, when you talk to command, obviously we're not here to tell command how to do their job, but when we're talking about their soldiers, our patients, that's what they are. They're both, right? And we need to be able to talk to them about how we can reduce that suffering. So again, the whole point of this talk and what I want to drive home is how we can change this dramatic pause into this. So, task you all with that. And that is it. Thank you. And please, if you have any questions, I'm all ears. Questions, comments? Yeah.
That there's a lot of conversation going around about systems level intervention. Wall Street Journal just recently wrote an article about residents trying to unionize and whether or not it's appropriate for us to even have these unions. Like, what does that mean in terms of like the sacrifice that would be in regards to like there obviously are some learning benefits of suffering, right? So my husband and I were talking about this recently. He's a surgery resident, and he said, if I were to limit myself to 60 hours, how would I learn in the OR? Do I just leave? So I'm curious what your perspectives are on
where is the appropriate amount of suffering from a systems level?
Yeah, I think it's going to ultimately be first. Well, yeah, I mean, obviously, it's always going to be personal to the person to kind of start noticing those signs and symptoms. So I think in terms of the systems level, I think it's really important to teach people what those signs and symptoms are. Because absolutely, right? I mean, at the end of the day, you got to put in those 10,000 hours, right? We got to put in those hours to be our experts. And we learn through that. And yes, we do have to suffer a fair amount to get there. But I think what is going to be most important is to task those systems to teach the residents, teach the students to notice those signs of burnout, to notice those signs where, okay, I'm starting to get, to get back to my bell curve. Apologies for homo again. I'm starting to get on that side. I'm starting to go down that slope there. And I think that's where it's going to be most important in terms of systems process. I can't give you like an exact number, like 60, 70, 80, I don't know. But the whole idea, I think, is going to be noticing what those signs are and feeling comfortable, feeling like you're not going to be like ostracized or looked down upon if you start asking for help. So that's where I think it's most.
Excuse my voice, I lost it over the weekend. Sure. One thing that I feel like I experienced a lot as residency with treatment care is while I was still trying to protect my own wellness, was looking after the wellness of the interns and the sub-interns that were here with us. It's very difficult to find that balance sometimes, and it's hard to create a systems process for that because that personal touch gets lost when you outsource that kind of care. How do you recommend taking care of yourself while taking care of those beneath you or those that you're leading?
I think it's a great question. And I think you hit on that depersonalization really well, because like you said, you lose that personal aspect of it, and you start getting a little jaded by that whole process. I think reaching out to your colleagues is probably going to be the best thing, the best start, right? And I'll be honest myself, I told you guys I was feeling burnout at a certain point. Second year I think is what hit me pretty hard. Reached out to Chelsea. We were office buddies before we were even in third year, and we had coffee and we sat down and we just talked about it. And that helped me so much. I can't even, I'm getting emotional. I can't even tell you how much that helped me. And I think that would be the first step, is just to reach out, and shoot, hit me up, we'll get coffee. But I'm serious, like reach out to a friend, because that can help so much in this whole process. And guys, we don't need to suffer silently. We don't need to suffer alone. We're all going through the same thing. We're all suffering in one way, shape, or form. So please reach out to your friend, reach out to your colleague, just talk about it. It really can make it so much better just to go have coffee. All right. Yeah.
So I thought it was really great wording that you used earlier about the maternity kind of events. I think you said it's an elite group that kind of made the system as it is. So with that comes resources, and I think this touches on Veronica's question. How much do you believe having increased pay, for example, can kind of offset some of these things so that people can better afford things like childcare or help with their chores and with all these crazy hours, things like that. I think the older I get, the more I realize that might be a significant factor. What are your thoughts on that? Where did you come across?
Yeah, no, that's a great point. And so when I was looking at the attrition rates, one thing that they had talked about that could potentially be a reasoning for psychiatry was the Medicare funding. That could be a lot of why people are dropping out, is because they're just not paying for it, right? So, yeah, I mean, we've heard, we hear down the line that as fourth years, this is in our chat all the time, like what's the term I'm thinking of? Retention rate is. The retention rate's going up. So I think that that's just going to be a peak and trough kind of thing. Like it's going to follow this sinusoidal pattern in the sense of like when we're losing people, they want to keep us on. So they're going to start paying you more, which is great. But yeah, I mean, I haven't come across a whole lot other than like just what I said, and the potential reason for why we're losing psychiatrists is that just Medicare is not helping out. We're not making enough from it. But obviously there's more reasons behind it. Yeah.
what's the source of the attrition data? Like, is it lost in Medicare, Medicaid enrolled providers or dropout from GME? Like, what's the source of that?
I believe it was, I have it right here in front of me. I believe it was dropout from GME.
Oh, geez. So like almost 1 in 10. Like you're dropping out of your residency. That's wow.
Yeah, I believe it was. I don't want to 100% say that right now. I have it right in front of me, but sorry, it's just not coming to me right now. Annual attrition rate divided on the number of residents leaving prior to completion of their training during an academic year. So yeah, so they compared the number of residents leaving prior to completing their training during an academic year by the number of active residents at the end of the same academic year.
Basically,
I wanted to, comment on how much I appreciate you bringing the aspect of reaching out to students in particular, especially thinking about us as a training institution. We have a lot of MSBs coming through our program on a regular basis. I know I was in that position at one point, and I remember coming through the I was in my picture period. I remember having residents reaching out to me when I was going through that, and that really made a world of difference. I think we see so many coming in and out, maybe just like reaching out and saying, hey, like, you're here if you need anything, or if there's anything that you need that we could makes a lot of difference.
Yeah. Absolutely. Guys, it can be so easy to just say, hey, you know what? That's all you have to say.
I wanted to add to Candace's point real quick. We don't talk about the economic factors very often in medicine, but I think it's becoming more salient now, especially because the income has been flipping in the economy. So even after 8 years of training, after he's in med school, for his residency, you'll still make less than a Walmart manager who makes $300K a year. That's like a big dissonance factor. Just wanted to add to the discussion.
Yeah. New perspective. Yes.
Hey, thought it was interesting you brought in the religion aspect to this. And I was wondering if you had any thoughts on the fact that, like, as a society, Western culture in particular, there's religion plays less of a role in most people's lives anyway. So do you think that cultural shift has an impact on sort of what you were saying about different religious perspectives?
I think so. And I think I'm gonna use another thing I saw in that article. They talk about loose versus tight societies as another reason to explain why the Chinese students in that study were more positive. And they talk about how in a loose society, we're less likely to adhere to kind of the societal norms, the societal rules. So they gave the example in like COVID-19, while the restrictions came out in a tighter society, like in China, they were more okay. There was less like, well, I don't want to do this, right? They were more okay with like, okay, that's just the way it is. They're in that tight society. Got it. Good to go. So that because of that, there was less like harboring resentment. There was less, and there was more ability to kind of see the more positive side of things. So in the same sense, I think, sure, I gave the example of like Christianity and how we see suffering as punishment. As you kind of move away from that, you kind of go into this looser society where it's like anyone's game, right? We're not really tight anymore. So you probably do start to lose that. It's kind of how I would think about that. Yes, Dr.
So just one comment. I think for resident wellness, at the GME level, it irritates me when I see like those free pizza days and things like that. Because it implies that there's something you got to do at the individual level. Burnout or organizational system issues. And so to frame my question, you're a 7th regimental psychiatrist soon, right? So the commanders have to juggle mission accomplishment versus troop welfare, right? We don't know where they are on this bell-shaped curve. We don't know where new stress is and where this stress is, right? So how do you think your topic that you discussed and some of the research that you did, how would you apply that when you are discussing, having a discussion with your regimental commander in terms of, yes, doing mission accomplishment, but also maintaining troop welfare?
Yeah, I mean, when I was writing this, or when I was creating this PowerPoint, my whole idea behind it was to make this a template. Not like I'm like planning on how many different templates I can fit this into, but I wanted to make this as generalizable as possible. So bell curve of suffering, bell curve of mission accomplishment, whatever you want to call it. But what I mean by that is like, I think having a discussion with command and saying like, hey, we're here to get the job done, but what happens when our intent to get the job done, it goes so far past what it needs to be that we start losing people and we start not getting the job done, right? We try so hard to get the job done. We grind these guys into the dust that now we're starting to lose people. Now we're starting to lose them to sickness, to mental health. So I think finding that balance of like, again, here's how much we can ride them. And I think you just got to work together with command to do that, if that makes sense.
Well, how would you know where the population is on that curve?
I think
It's a leading question.
Yeah, I know you're getting at. I think doing like doing surveys. I think what I'm blanking on the word, but in terms of the when we did our
You have it at 1,500 today.
Yeah.
Yeah.
Pulse. There it is. Thank you. Pulse. PH Pulse. I think reaching out and trying to like figure out, gauge the system when you get there. When I get to 29 students.
Yeah, I think this is more of a discussion. I think for us, we prepare you pretty well to take care of the individual. But one of the areas we need to do better is how do you help commanders, do better at population level? So our medical colleagues, they have it somewhat easier because they can count the number of profiles for limb dues and injuries and so on. For us, it's much more ambiguous. So the thing I'm going to recommend is, and we don't have it in our curriculum yet, because I don't have anyone to teach it, but things like organizational psychology and work psychology has a lot to offer. So there's this concept called work design, where you take someone who's bored all day, or don't have a sense of meaning and purpose or accomplishment, and then you talk to the command or their seniors or supervisors, and you say, I recommend you do this with this individual. And you can specifically, prescribe them this work design concept. And then they do that, and the idea would be that they have a much more positive experience at work. So I think when you think of burnout, if someone is telling you you need to do more yoga or exercise more, I think those are fine for cardiovascular health. But burnout, these things are work culture, right? The amount of quantitative stress, meaning how much quantity of stuff you're expected to do, and qualitative, how high quality of stuff you have to do. And so these are the things that you got to balance. It's a challenge for me. There's certain stuff that you have to know. You can't leave here without knowing those things. But how do we do that without totally burning you out? So
I have a final comment. This is for Veronica, and then piggybacking off what you just said. I think we try to equate like our work time with the amount of work done, right? But we just need to figure out how to do it more effectively, right? So learning more effectively, I can shovel 100 hours and won't beat heavy equipment. It's just impossible. That's my final comment. That's all the time we have, unfortunately. Thank you for your discussion.
Thank you.